just in case. So after the APGAR score, you have to know that how do you calculate the APGAR scores, just like how GCS can be asked. So you need to know the APGAR score. So appearance, pulse, grimace, activity, and respiration, and at which level you have to give the 0 and 1 or 2 points. Then comes to the most commonly tested disorders in the newborn. What are the one that you have to test? G6PD deficiency, which is basically an X-linked trait. Then phenylketonuria, which is an autosomal recessive genetic disorder. Then comes the galactosemia, a very rare genetic disorder with the normal metabolism of the galactose. Then the congenital adrenal hyperplasia, as we already discussed yesterday, 24, 11, and 17 is there. Any of the several autosomal recessive disorder that helps to find that, if the child is going to be having any genital abnormality or needs any genital reconstructive surgery. Then congenital hypothyroidism is one of the most common a condition that is basically affecting in 1 or 4,000. So you need to know which one are that. So in that one, hearing test excludes the congenital sensory neural hearing loss. So this line is very, very important, necessary for early detection to maintain the speech patterns and assess the need of the cochlear implantation. Cystic fibrosis autosomal disorder causes the abnormally thick mucus. Best initially test sweat chloride. Most accurate test is genetic analysis of the CFTR. Combination of the elevated sweat test, presence of the CFTR abnormal functioning in at least one of the organs. So it helps with the diagnosis. 30-year-old with the ulcerative colitis presents with the fatigue, jaundice, and pruritus, so it could be PSC. Valerie-Weiss is basically superficial tear in the esophagus. Bohr have full thickness esophageal ruptures. Mother with hepatitis B, C, pregnant, allow the mother to breastfeed. There is no document evidence that the breastfeeding spreads from hepatitis B and C. But in HIV case or immunodeficiency, that's a different thing. Absolute contraindication is basically HIV and TB, or absolute contraindication to the breastfeeding. Herpes of the nipple is contraindication as well. What is the best indicator for the acute malnutrition? So weight divided by height ratio less than 5 percentile. So it's basically for the malnutrition. What is the best indicator for under and overweight? Basically BMI. What is the most common cause of the failure to thrive in all age groups? It is psychosocial deprivation. What is the next step in the management of causes of underfeeding? So it could be the child neglect. And so in those cases, we do the CAS. Usually it's like Child Aid Society, not the protective services. Then clavicular fracture. This is the most common newborn fracture as a result of the shoulder dystocia. X-ray is the best diagnostic and the fracture is treated with immobilization, splinting, and then physical therapy. Meconium aspiration syndrome regime is airway management and ventilatory support with oxygen therapy, inhaled nitric oxide. If the patient worsens, then initiate the surfactant therapy, which works to break up the meconium in the alveoli. If the patient still does not improve, the next step is management in the extracorporeal membrane oxygenation. Omphalocele, so you need to see how does the picture of omphalocele and gastroschisis, how does they look like? Is the highly associated with Edwards syndrome? Elevated AFP indicates level indicates both neural tube defect and abnormal abdominal wall defects. So the most common cause of the elevated AFP is basically incorrect dating as well. Umbilical hernia. With umbilical hernia, there is a congenital weakness of the rectus abdominis muscle, which allows for the protrusion of the vessels and the bowel. It is highly associated with congenital hypothyroidism. 90% close spontaneously by age. Age 3. After the age of 4, surgical intervention is needed to prevent the bowel strangulation and subsequent necrosis. Then comes the Wilms tumor. Wilms tumor is the most common abdominal mass in the children. Total nephrectomy with the chemotherapy and radiation may be indicated based upon the staging. Bilateral kidney involvement indicates the partial nephrectomy. Wilms tumor, anheridia, genitourinary malformation, and the mental retardation are regarded as the Weger syndrome. So see how does the Weger syndrome look like. The syndrome results from the deletion on the chromosome 11. So today we'll do 15 and then we'll do from here on tomorrow, okay? So we were talking about the common differential diagnosis associated finding and diagnostic approach based on the age. So we already discussed this one. Then the management, we already know that the rehydration, because the vomiting is there, so you have to watch out for that one. Antiemetic drugs not recommended when unknown etiology or anatomic abnormalities. Then gastroesophageal reflux, as I already discussed, the most important is the back arcing, respiratory symptoms, sleep disturbance, all of them are there. Infants is different, and the older child or adolescent represents different. The investigation is thriving baby requires no investigation. Then GERD, upper GI series, esophageal pH. Then the upper endoscopy and esophageal biopsy is the one that you do to figure out what's going on. Then the warning signs of the thing that's more important. What are those ones? The bilious vomiting, GI tract, bleeding, forceful vomiting, fever, lethargy, hepatosplenomegaly, the bulging fontanelle. Then comes the microcephaly, and then the seizures, abdominal tenderness, suspected genetic, and then metabolic syndrome. Usually for the infants, we go for conservative treatment and mainly changing the formulas. For the adult, we go for conservative, like where we start PPIs. Short-term parental feeding to enhance the weight gain. PPI H2 D2 agonist intervention is nice and fundoplication. Then these of the recommended should be used with the cautious. In the complications, it causes the oral feed aversion, then poor weight gain, aspiration strictures, and then Barrett esophagus. We already discussed these, all of them. Then comes the diarrhea. In the diarrhea, you just need to know the differential diagnosis. And when it comes to how you do, you have to rehydrate. So just that one. Diarrhea is defined as an increase in frequency and decrease consistency of the stool. So normal is basically 5 to 10, and then children. Then what are the red flags? Having bloody diarrhea, fever, petechiae, purpura. So in those cases, there could be something underlying. Common antibiotics that can lead to Clostridium difficile infection is basically fluoroquinolones, clindamycin, penicillin, and cephalosporins. So when we do investigations, so don't forget about the stool culture and sensitivity, ova and parasite. Then we go for something else. So here you can see what are the differential diagnoses for acute, for chronic. So they are kind of different. Then gastroenteritis, you can see this table. It will help you more than enough, okay? The management is prevention and the treatment of dehydration. So early refeeding syndrome, and then ondansetron should be given, antibiotics, antiparasitic. And one of the most important thing in viral bacterial infection, you have to notify the public health. This is one of the things they are looking for. After treating or whatever is going on, if you have seen too many cases, what will you do the next? So as a family physician, the main aim is yours is notifying to the public health, promote regular hand washing, and then return to school, if then giving the rotavirus. Toddler diarrhea is sometimes given in the differential diagnosis, and you need to know it's a toddler diarrhea. So usually with the 6 to 36 month, which is where the children start, doing the crawling and stuff. So in those cases, it's very common where they put things in the mouth and all that. So what are you going to do is 4F, adequate fiber, normal fluid, low dietary fat, and then the discourage the excess fruit juices. So don't forget about the fruit juice, okay? They can give you a scenario where they give you extra fruit juice and asking the patient is having diarrhea. In that case, the counseling is mainly the fruit juice. Then lactase deficiency is mainly something that is very popular and very common in Canada. So in those cases, going for lactose-free diet. Then comes the cow milk allergy. Cow milk allergy is, I already told you in those cases, what you need to do is basically finding out what you have to give if the patient is diagnosed with cow milk allergy, and in which cases, at which point you have to start the cow milk. So what is the investigation? Investigation is food challenge. That's the gold standard. So skipping the cow milk from the diet, that will help you more than enough. Then skin prick. Test can be done to find out if he has any allergy, serum investigations of the allergen-specific IgE and patch test. Usually we go for food challenge, and that's more than enough. Then management is IgE mediated CMA, stop exposure, epinephrine should be given if it's like an allergy or as like, anaphylaxis reaction. If it's non, then just reintroduce the milk in 6 to 8 months. So first stop the milk, and they will definitely ask you when are you going to reintroduce the milk. This 6 to 8 month is important, okay? Just highlight this one. And majority with the outgrowth by 1 year. And what are the formulas? So casein hydrolysate formulas should be used, or the mother may be used to remove the cow milk protein. All bovine protein, soya protein, legumes, and continue the breastfeeding. With the calcium and vitamin D intake. So if they can ask you if a child is taking mother breastfeeding, what else you will introduce? So in that case, we do introduce iron, calcium, and vitamin D. So don't forget iron. Then comes the constipation. a lot of children do have constipation. So in that case, is the main important is education, because the education is one of the main important factor to deal with the constipation. Then cleaning out, maintenance is basically giving enough fluids, stool maintenance, dietary fiber, uh, toilet training. Children should be treated at least for 3 to 6 months and should not be weaned from the maintenance therapy until they are having regular movement. Then follow up with them. So in the abdominal pain, always think of even a female come like after, let's suppose 13, 14, and she's menstruating. So don't forget about beta HCG. And whenever a female or a male, whatever child comes and he's excessive crying, don't forget about UTI. Okay. Then appendicitis, we already discussed about this one. Then perforation is one of the most common in the young children's. Intussusception, just see how does it look like. So it's a telescoping and mainly the classic triad abdominal pain, the current jelly and the vomiting. So what are the diagnostic treatment or the therapeutic one is the air enema. So remember this word, highlight it and keep it in your mind. Air or saline contrast enema can be therapeutic, so reduction under the hydrostatic pressure, but it has to be very carefully done so no perforation can happen. So functional abdominal pain, in those cases, go for the fecal studies, checking out if there is any gastroenteritis or any overt parasite is there, checking for everything. So in those cases, the most important is doing the fecal studies. Continue to attend the school, manage an emotional, and then go for 4Fs. Same we discussed, fiber, fluid, lactose-free diet, all of that. Medication rarely used. Otherwise, you can always start amitriptyline, but it's too early to start in the young children's. Then comes the abdominal mass. The most important is Wilms tumor. We already know that this one is very common. Then comes the polycystic after that. Polycystic in that one is mainly because it has some connection with your brain as well. So you could have aneurysm or later on develop some sort of BP problem. So that's why polycystic is important. Progressive renal failure and urinary tract infection is very common. Hematuria. So management is BP control, dietary, sodium restrictions, statins, and vasopressin. Then comes the Wilm tumor. In those ones, is there is a mass, mainly with the pain and hematuria. So usually the treatment is surgery and all that. The bleeding will be managed as we already discussed, how you need to ABC, then NG, NPO, Follies, and all that. That's how you manage. When it comes to hematology, I am not a very big fan of doing a lot of hematology. I mean, in my time, I did not do much from hematology. I tried to, but then I wasn't able to do much. So in children's thalassemia, iron deficiency anemia, yeah, and if possible, you can read sickle cell. So, and then vitamin B12 in older people. So these are the 4 5 that I personally, feel like at least you should do that. Then the physiological anemia is basically high HB more than 170 should be there, and reticulocytes at the birth is caused by the hypoxic environment. At birth, levels fall to like blood HB level falls down to a shorter RBC span, so it's normal. So you have to counsel the mother. It will be like that during first 6 to 8 weeks, and then it's going to be getting back to increase the blood volume to growth. Then the lowest range is about 100 at 8 to 12 week level. So it's basically in the premature level rise spontaneously with activation of erythropoiesis. Then when we are talking iron deficiency anemia, children will be eating like, maybe ice, some extra whatever things. So in those cases, always think of iron deficiency anemia. If the child is having colicky, tummy pain, irritable, crying often, constipation. So in those cases, always think of iron deficiency anemia could be there. So usually a lot of children do present with asymptomatic, but as I said, these are the side symptoms which we are or mothers are neglecting in the start. Then how are you going to do is basically CBC, HB, MCV, then Mentis index is MCV divided by RBCs. If it's less than 13, then it's thalassemia. If it's more than 13, then it's iron deficiency anemia. Then go for ferritin, TIBC, whatever, all of them. Starting with the breast field and those ones begin iron supplement. That's why I said whenever they ask a question where they says that a mother is breastfeeding, what are the supplements that you would like to introduce? So in those cases, you have to add iron, calcium, vitamin D. So don't forget about iron. Continuing until they're able to eat more than 2 feeds of the iron-rich food, and then non-breastfeed terms infants give iron fortified formula from the birth. Then the premature infant give iron supplements begins at 2 weeks. So when are you going to start for the premature? It's mainly at the 2 weeks, and then continue at least 2 milligram per kg per day. No cow milk until 12 months. This is the line. This is very, 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 very important. Just highlight it and keep it in your mind. Early introduction of the red meat, iron rich, total daily iron should be 11 and then 7 milligram. So consider screening for HB because of the checking for iron deficiency anemia. Then always encourage the meal and iron deficiency. You can start the iron pills and all that. So after starting the iron pills, you can always counsel about the constipation, black stools and all that. So in this complication, the one is angular cheilitis and glossitis and chylonychia. So they can give you a picture and maybe ask you to make the diagnosis. Usually in vitamin K deficiency, a female can present with a lot of menstrual bleeding, or a male can present mainly with the mucus bleeding. So these are the main two cases that can be presented. Or epistaxis could be there. So usually it's a one vitamin K. So in that case, it's giving vitamin K. Or in that case is where they says that the baby was born or delivered at home or with the midwife. So in those cases, a baby was not given a vitamin K. So that case is very, very common. So prevented with the vitamin K injection at birth can be taken orally. So they will give you that the child was not birthed or born in hospital. So in those cases, vitamin K deficiency is very, very common. Um, then you feel like going through thalassemia, so you can do a little bit more about thalassemia. Only, I mean, knowing that beta thalassemia and alpha thalassemia, main things. Like it's as a family medicine, we just need to know the diagnosis, and after that, it's usually referred to hematologist. Then the G6PD deficiency protects against the parasites like malaria. Then is the bleeding disorder. So it's something that you could memorize and it helps you with a lot of diagnosis. So you can remember this one, like hemophilia 1 has approximately everything normal except for this PTT. And then hemophilia B is also normal except like it's not hemophilia A has PTT and eight factor, but B has only PTT. So try to remember it. If you can start making sense with it, then you just go with it. Everyone has its own way to memorize it. So Von Willebrand go with the PFA, PTT, DIC go with PFA and then PTT as well. Vitamin K usually go with PT, PTT. Thrombocytopenia is basically only for the PFA, platelet function, as say. Then the extensive bruising in the absence of the lab abnormalities, always consider the child maltreatment. And then wherever you consider that there is a child abuse, go for CAS. So in ITP, the main important, they can ask you to make a diagnosis, usually. So involve the family in the management, shared care decisions. So no or minor bleeds, just watchful waiting. Moderate bleeding, usually IVIG, and swear go for steroid and IVIG. So just for your idea, constitutional symptoms, as we already discussed, fever, chills, night sweat, and the weight loss. So Wilms tumor is also related to the Weger syndrome, Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation. And back with Weidman syndrome, I would suggest if you can see a little bit because it has enlargement of the body organs. So usually you might mix it with the like growth hormone or like Klinefelter or those other ones. So that's why, just for your idea, it also has enlargement of the large. As you can say, it says wide. So from there you can think of enlarge. Okay. Then Dennis rash, I would say, I mean, it's just something that could be given in the like we know in this MCQs, like as inside option. So, if you don't know anything, at least Dennis Drash, and then you can say, oh yeah, this is this one or this is not this one. Just for that. It's Dennis Drash is mainly for the like genitals. Think of Dennis as in genitals. So gonadal dysgenesis or nephropathy. Then the neuroblastoma in this one, there is one thing here. Yeah, the Horner syndrome. So it has a thoracic involvement where it comes with the dyspnea and the Horner syndrome. So wherever they give you a little bit of this one, so basically this is neuroblastoma, and its main common site is adrenal gland. Then comes the fever. In the fever, it's very common, the fever of unknown origin. So let's go with this table. In the fever, the fact age is very, very important, especially in the children's. So if we are talking about age less than 28 days, in those cases, regardless of whatever it is, admit and go for a full septic workup. Full septic workup includes everything you can see from here. So a partial includes blood, CBC, differentials, urine, culture sensitivity, LP, chest X-ray, stool culture and sensitivity. So all of that one. But when it comes to full septic workup, it includes like mainly the usually we don't go for stool culture and sensitivity, LP, and all of that one. So in the full septic workup, we usually go for invasive techniques as well, along with the other ones if needed. Then the fever, if this is basically age 28 to 90. So in those cases, we see if the child is toxic, non-toxic. They will definitely say in the scenario the child is toxic looking, not toxic looking. So if it's a non-toxic looking and you feel like the parents will be able to do follow-up, so they will say that parents are saying that they will do a follow-up and they have been doing a follow-up or they are good with follow-up. So in those cases, go for the low risk criteria. In those cases, do partial workup, give antibiotics, and may consider treating as an outpatient and always come for a follow-up. In other cases where you find this is toxic looking, along with they are not reliable with the follow-up and you feel like there is child neglection, so admit the patient and do the full septic workup with antibiotics. Then comes the age 3 months to 3 years. You have to see if it's a toxic, non-toxic. Then if it's a toxic, believe me, the words in the MCQs or exams is simple, straightforward like that. Toxic, it's basically admit full septic workup if it's a non-toxic and no focus, like a child neglect is there. And then temperature. Temperature is more than 39 where you feel like, yeah, he could have or she could have developed meningitis later on. In those cases, always, 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 wherever fever, always think of UTI first, then going for anything. So because this is a urine dipstick that you can do right away. So urine dipstick or urine culture and sensitivity we do, and then CBC we do. In those cases, then we check for WBCs. If WBCs is more than 15, go for blood culture and sensitivity, urine culture and sensitivity, and giving the Tylenol. But if the WBCs is less than 15, then culture and sensitivity, observation, acetaminophen, or follow up in the 24 hours, sorry. Then it comes to the temperature less than 39, so urine culture and sensitivity and observation. As I told you, in the children, especially above 3 months to 3 years, the first thing about fever, keep urine thing in your head. Because a lot of child or babies cannot tell you about the urine symptoms, so they were just crying and having fever. So our main focus is thinking of urine. Then the road test criteria is on the side, that WBCs, then urine analysis, stool, and then past health. Past health includes born more than 37 weeks, like it's not premature, home with like full care, no neglection is there, no hospitalization, like there is no immunocompromised child, no prior antibiotic, no prior treatment, hyperbilirubinemia, or no chronic disease. So as we already discussed this table, in those cases, you need to do the treatment. Now comes the acute otitis media, like one of the most famous and most important topic from pediatrics. Like if you have, I would say, 1 week left before the exam, at least do revision of this one. Then it's basically the bacteria are Staphylococcus pneumoniae. That's one of the common. Then group A streptococcus, others are anaerobes and all that. Then the stitching tube related, so it's basically a respiratory tract, allergic rhinitis, all of them could be there, and then cartilaginer and cystic fibrosis if they are having over and over again. Mm, then let's directly do this table. Management of acute otitis media. If more than 6 months of the age, generally healthy, acute onset of the illness with or without fever may or may not manifest other signs of middle ear infection like vomiting, pain, dependence on the age or the verbal symptoms is there, then suspect acute otitis media. In that cases, it could present with in three forms. Okay, perforated. In that case, is obviously going for antimicrobials, and usually we put for the tympanic membrane tubes as well. So we do refer to ENT if needed. So perforated, in that one, you have to do the antimicrobials. Then comes the middle ear effusion present with the bulging tympanic membrane. It means the rupture can happen in any time. In those cases, you made the diagnosis on or the treatment based on the if the child is mild looking or a moderate or severe looking. So what happened in the mild looking? In the mild, he's alert, no rigors or antipyretics, mild otalgia, able to sleep less than 39 and 48 hours of illness. So he's kind of like doing okay. So after discussing with the caregivers, you can always do a follow up and then observe for 24 to 48 hours. If not clinically improved or worsening, then in case go for antibiotics. As you can see, we are not giving antibiotics even though he is having middle ear effusion and bulging membrane. So that's why you have to see in the scenario after giving just this tympanic membrane, what are they saying? If the child is cranky, crying, is he eating okay? Is he sleeping okay? So in those cases, going for antibiotics, okay? Even when I'm working in a clinic, my main focus is not like what the symptoms or what the presentation is. My main focus is if the child is eating, sleeping, whatever those things, because with that you can feel how worst is it going on. Then moderately or severely ill, irritable, difficulty sleeping, poor response, antipyretics, otalgia, pain is too much, she's cranky, crying, vomiting, not eating okay, or stop eating. In those cases, absence of antipyretics, there in the absence of antibiotics there is temperature or it's going on for at least more than 2 days, so in those cases giving antimicrobials right away for 10 days and 6 months to 2 years of the age, and for 5 days for 22 years of the age. So you don't need to remember for how long you have to give, just antimicrobials, and for how roughly it's for 10 days. Okay, just roughly. Obviously if it's sometimes someone younger, so you have can give him less age. Then without middle ear effusion or with middle ear effusion but no bulging, no mildly erythematous, nothing is going on. So in those cases, you have to consider viral, such as RSV, influenza, reassess in 24 to 48 hours, ask them to come back if clinically improved. If clinically worsening, to verify the presence of the effusion and signs of middle ear infection, such as bulging tympanic membrane. Now coming back to the management. So management is basically, obviously you have to give antipyretics, okay? Watchful waiting if the criteria met, as we already see the child is doing okay. Then comes the antibiotic. In this one, if less than 6 month or moderate severe illness. So in that case is not just amoxicillin, you need to know high dose amoxicillin. Okay, you don't need to remember the doses like 75 to 90 milligram per day or whatever it is. Just remember that high dose, it's need to be written as high dose. Okay, so in the MCQs they might give you amoxicillin, low dose amoxicillin, high dose amoxicillin, so you need to know it's high dose amoxicillin. Then BID for 5 days, because we saw it's if less than 22 months, so it has to be for 5 days. 10 day if the age is as I said less than 2 years, perforated tympanic membrane. So in that case is then comes that second line, then that's amoxiclav, cephalosporin, cefixime, used when the antibiotic, acute otitis media, unresponsive and clinical symptoms persistent more than 48 hours, as we already discussed with the table. Signs of perforated tympanic membrane should be treated with the antimicrobials and examined by complications. Prevention is patient education about the risk factors, pneumococcal vaccines. So this is important. Ask about what is the prevention. So giving the pneumococcal and influenza vaccines. Then the tubes are important. In that case, we just refer the patient to the ENT specialist. Or even in the history, sometimes they do ask. So in those cases, the first thing that I do like to ask is basically asking about previous tympanic membrane, previous tympanic tubes or the previous infection. Okay, it means the child or whatever who has previous infection, they are more prone to have any new infection and their rupture of the tympanic membrane perforation, and then it can lead to meningitis, abscess, and everything. So acute otitis media is one of the most important topic. Don't ever miss this one. Then comes the effusion. We already discussed how we are going to deal with the diffusion. So it's basically the ENT referral. Then the most important complication is the hearing loss. Usually for me, that's one of the thing. Like it's a very important MCQs. Like it can cause just hearing loss is not important. I know the word here is hearing loss, but acute otitis media usually cause conductive hearing loss. Okay, the word is not hearing loss. The word is conductive hearing loss. So please correct it and write it down on the sidebar. So usually sensory neural hearing loss is mainly genetic, and conductive hearing loss is mainly from the acute otitis media. So very, very important MCQs or very, very important knowledge to keep it in your mind. Then the chronic mastocytitis, ossicular erosion, that's why they have conductive hearing loss. Cholesteatoma can be formed under retraction of the tympanic membrane, atelectasis, and then ossicular effusion. Then comes the common infection, pediatric exanthema. How does they look like? What's the presentation and all that? Just that management, and if there is any complication or any vaccine that's available for that one. Simply that's what you need to know. So that is basically the fifth disease. How does it look like? The slap cheek. So you see a picture. How does it look like? So appearance is mainly the erythematous plaque and lacy rash on the both of the cheeks. So they can present with a mother saying that my baby is having both cheeks, rash, there is over there, and she, or baby is having fever. So in that cases, so the complication is that rash fades over, but may disappear months later with the sunlight exercise. Uh, and then what is the complication? It can cause the transient aplastic crisis. Then if you can read this one, Gianotti-Crosty syndrome, it's mainly with the EBV hepatitis B vaccine. That's it. Then the hand, foot, and mouth disease. This is very, very common. And we know that they do like to give you the picture and do ask you for the hand, foot, and mouth disease. This is mainly caused by Coxsackie virus. So knowing the virus is very, very important. So it's mainly the vesicular rash on the posterior oral cavity as well. So always think of this one too, that they will give you this one too. That vesicular rash is on the oral cavity, uh, especially the pharynx, like like specifically in the back, it's there. Then comes the herpes simplex, is basically HSV. In this one, you can see like the painful rash in the mouth or in the genitals. Then Kawasaki disease, we already know how does it work. The measles, so Kawasaki can be misdiagnosed with hand, foot, and mouth disease. So you have to know the difference between. Then the measles one, the measles, we know that it's where does it start from? Xanthema, Koplik spots, one of the things. So that's why the measles has Koplik spots, but the hand, foot, and mouth disease has the posterior, like in the pharynx or in the tongue, they have the vesicles. Okay. Then the secondary complications is otitis media. They kind of all kind of infections, and the main is the thrombocytopenia. Then the enteroviral xanthema is basically caused by enterovirus, so there is polymorphular rash. Then roseola. There is one more, I think that's called rubella, and then roseola, and then I don't know, there was one more. That's something, I don't know, I'm just mixing up with something. Anyways, then herpes virus, human herpes virus, how does it look like? This is basically a blanching pink maculopapular rash. So appears over fevers, and then they are starts at the neck. So this one usually starts at the neck. So main important is you need to know the measles, roseola, varicella, like chicken pox, where they start from. Because from the starting, they will tell you, oh, my, like this fever rash started from the neck, this rash started from forehead, this rash started from hand. So that's how you can make the diagnosis. So common is irritability, anorexia, lymphadenopathy, and then is all this coryza and bulging fontanelle is there. So this can also cause the thrombocytopenia, as you can see from the side, meningitis and all that. Then the rubella is there. This is called by ruby virus. In this one, it's a good prognosis. So as you can see, sorry, I forgot to mention here which one is to report to the public health. So measles is supposed to be report to the public health, and in this one is the MMRV vaccine. Then there is the rubella that is also reported to public health. That's important, okay? And then prevention with MMR. So it causes the arthritis. Then there is varicella. Varicella is also reported to public health, and its vaccine is MMRV. Okay, so this one here. Then the infectious mononucleosis. This is one of the important. In this one, the most important is how does it transmit through saliva. So kissing syndrome, kissing disease. In this one, infectious contact, and then comes the sexual active, and then sexually partners. So in those cases, the main important is talking about the spleen, that hyposplenomegaly is there, and then you can do the monospot test. Although it came out false positive most of the time, but usually we go for monospot test anyway. So EBV testing, and then CBC, and then throat culture to rule out the streptococcal pharyngitis. So how do you, if a patient comes to you with the cough, sore throat, how do you go for the infection mononucleosis? So checking for the, in that case, is going for the abdominal examination. So that's how you find out that, it's very, very important. If any person who comes to you with a sore throat, you have to check for the spleen. I know it's a very like common, not very common practice, but you should keep it in your mind that you have to do the abdominal examination to check for the spleen. Okay, so it saves a lot of time. Then you don't have to go for monospot test, and if you feel like you can palpate the spleen, so it's a splenomegaly, so go for the monospot test to confirm the diagnosis. Anyway, there is no treatment, so it's to be safe. So most common resolves within 1 to 2 weeks. So you have to talk about this one, and then later on it can cause splenic rupture and Guillain-Barré syndrome. Then acute pharyngitis or infectious pharyngitis. In this one, the sore throat is very common presentation, and checking for the throat culture and sensitivity. Okay. So if they ask you what are the first line investigation, or what is the first investigation that you would like to do for any kind of sore throat, so usually going for throat culture and sensitivity. Don't go for CBC or anything. So this is the presentation is this one, as you can say, sore throat, upper respiratory tract infection, exudates, tonsillar inflammation, enlarged cervical lymph nodes, all of that one. Then the scores are used to predict if the throat culture and sensitivity will be positives. And Centaur score, uh, I mean, no one uses it, but still, yeah, you can go for this one. And then those scores may not be found to be sensitive. So I don't know what's the point of doing it anyway. Suspected diagnosis of GAS can be confirmed with the rapid streptococcal antigen testing, and we do it a lot, and follow up the throat culture if the rapid test is negative. So even if the rapid test came out negative, you can always send for the throat culture. Antibiotics is, as you can see, this is penicillin 5, amoxicillin, and erythromycin is can be given. But in those cases, if there is an allergy, then you can go for different things like erythromycin. May prevent rheumatoid arthritis fever if given within the 9 days of the symptoms. Does not alter the risk of the post-streptococcal glomerulonephritis. So if it's not given within the time, it can affect the kidneys as well. Sportive is hydration, acetaminophen, follow-up, and prophylaxis is tonsillectomy. And then it can lead toward the scarlet fever, rheumatoid arthritis, post-streptococcal, because the strep throat is mainly leading towards all of these ones. Then the scarlet fever, it's very important. How does it look like? Mainly the strawberry tongue, because it can be mixed with the cover